Good morning, everyone. I'll just start sharing my presentation. Can you see this, Andrea?
Yes.
So this is the CME code for today. We're also going to put it in the chat. So we'll start with my case, which we were already presenting last week, and then Andrea will present the second case. So I'd just like to start by thanking the team that was part of the care of this patient, from neurosurgery, Dr. Q, Dr. Almeida, neuropsychologist, Dr. Sapsevitz, neuroanesthesiologist, Dr. Bojakci, neurooncologist, Dr. Sherman, and Dr. Servan from epilepsy, and then Dr. Gentle from pathology. So as we were presenting last week, this is a 34-year-old male that actually got to us already with a diagnosis. He first presented with a generalized tonic-clonic seizure in December, was loaded on Keppra and then placed on Keppra 1,500 milligrams BID. They did a biopsy. At the other institution, you'll see why they didn't proceed with the surgery. And the patient, once he was placed on Keppra, didn't have any more generalized seizures, but continued to have a lot of focal seizures that were mostly tonic stiffening of the right hand, some aphasia. He had never really lost awareness, so they added a second anti-seizure medication, lacosamide, and the patient actually had a good response when it comes to the motor component, but continued to have episodes that he could recognize as focal seizures, and that's when he came to us. So when he came to our institution on exam, he was mostly normal, awake, alert, in time, place, in person, intact when it comes to cranial nerve function, normal motor, normal sensation, normal gait. And at this time, you can see here that we were able to collect all the images, and how, as we were discussing last week, there were some interesting findings. In particular, you can see on the CT scan, which was the first exam that was done at another institution, the calvarium seems to be remodeled next to the lesion, suggesting that this has been there for some time and was actually remodeling the bone. And when you see on the T2 flare, it's quite intense, which you can also appreciate on the spin echo. We'll just try to get to the same cut. Interestingly, also, like Dr. Murray was also mentioning last week, you can see that there is some loss of signal when you compare the spin echo to the flare on the outermost region, which is a very specific but not sensitive sign to IDH mutation. So, and you can also see that on the innermost part, on the most medial portion, there was already some enhancement suggesting that this would actually be a higher grade lesion. So, of course, we already knew the pathology, but as Dr. Murray was also suggesting last week, this is a case where imaging actually can make quite an accurate prediction, since we can just from imaging alone suggest that this is an intraaxial lesion, mostly consistent with a glioma, that it is probably IDH mutant, doesn't have any calcification, so probably not an oligo, and there's some enhancements, so either grade 3 or grade 4. And I just have here that summary because this is one of those cases where imaging actually can make that kind of prediction. So once he came to our institution, we did a functional fMRI and a functional MRI, but before that, I just want to highlight some of the interesting anatomy based on the sagittal T2, where you can appreciate that the lesion on the posterior most end almost seems to confound itself with the border of the premoral, the precentral gyrus, and anteriorly it seems to be involving encroaching areas that are particularly important for speech, reason why we also proceed with the fMRI, namely parts opercularis. And here on fMRI, you see that we did reading and sentence comprehension paradigms and also evaluated motor tongue. And on the posterior end of the lesion, you do see a lot of activation here in this darker blue for motor tongue, whereas on the most anterior and inferior portion, you do see that there is important reading comprehension and sentence completion here in this green and magenta. I don't know if radiology is on the line and they would like to further comment. Okay. So this is a DTI that Dr. Mühlebrooks produced for us, a 3D reconstruction of the DTI. So you can appreciate in red the large size of the tumor And then we have three white matter bundles that are important to consider when we proceed with this surgery. In particularly, in blue, you have the frontal ascending tract. In green, you have the arcuate fasciculus, and in yellow, you have the SLF3. So these are very important bundles that one will have to always keep in mind when we're going to surgery, particularly at the innermost part of the tumor, when it starts being difficult to distinguish invaded and non-invaded tissue, where not we're producing a deficit because we're encroaching on this tracks. I don't know, Dr. Sapsevich, if at this point you have also any other comments on what you were thinking.
Well, I was going to ask anybody in the audience to comment on the functional correlates of these three tracks. Does anybody want to say anything, or do you want me to kind of go on about that?
I think that the frontal ascending tract is important for speech initiation, arcuate fasciculus for spontaneous speech, and then as SLF3 for also language articulation mostly.
Yeah, I mean, sorry, did somebody want to say something?
Hi, David, JP here. No,
Hey.
Diogo, just in terms of anatomy, I think one thing that is important as well before we go into the function, you see the connections. I think one nice way to think of all the tracks is kind of like, for example, the frontal ascending tract. Where is it going? Like, what two structures does it connect? Same thing with the arcuate fasciculus, and the same thing with the, with the other. So all the other tracks, it's just like when in skull base, which is more my area when we think about the muscles and the attachments, is the same thing you should think about the white matter here. Right. So you got to connect anatomy with the function, because this is exactly what Dave is about to comment. Do you know, for example, the frontal ascending tract, what is kind of like, what does it communicate?
It's SFG with IFG, like pre-SMA, SMA, and then like pars opercularis.
Perfect. Right.
And just adding to what JP is saying, I mean, we can infer function based on the functional connectivity of these regions. So, if you take SMA, we know that it's important for, initiation and maintenance of motor and cognitive control. And obviously, we've talked about the IFG as being important as part of the speech motor system. So you can see how they feed forward and feed back with each other, and how that would be related to verbal initiation and what we call, verbal fluency. When you damage that track, patients will slow down, their output becomes more effortful. So correct.
And I think Dr. Gupta is also on the line. I don't know if you have any further comments, sir.
If I may, I'm so sorry for interrupting, but Dave, just I would love to hear your further comments. So you just mentioned some about the frontal ascending tract. So just for our education, so how would you map the three of them that we see here?
Yeah.
What would you expect?
Excellent question. So, so with, we didn't comment on the SLF3 or arcuate fasciculus. I mean, I would not say they're important for speech articulation, because you're implying speech motor function with that. What actually those tracks do, like JP saying, think about where they start and where they end. Those tracks are part of what is called the dorsal phonological stream. So they're taking phonological processing that occurs back in the posterior STG and the supramarginal gyrus. So, pulling together those sounds that make up words, and is transferring that information to the speech motor system to express, right? So, how do I map arcuate and SLF3? I want to do tasks that will allow me to look at phonological output. So you can do picture naming, and you can look for phonological errors, so they may mispronounce words. I like having them repeat things, in particular non-words, and the reasons for doing that is that when you hear a non-word, it has no meaning. Like the word conflickle has no meaning. So you have to rely solely on your phonological systems to perform that task. So you're driving that system harder. As far as the frontal slant track is concerned, ideally we'd want to do something that requires some type of verbal initiation and maintenance. So you could do some type of verbal fluency type task during surgery, where they have to come up with words that start with a certain letter, and you're seeing whether or not you can disrupt either the onset of that production or the slowing in that production. And then the other test that some people will use is like a sentence completion task. So you can have a sentence like, grass is, and they'd have to come up with a word to complete that. So they might say green. So they have to access sort of a store of possibilities and select an appropriate word. So those are some of the things that we would do during surgery to kind of map those areas.
Thanks, David. Appreciate it.
And Dr. Sapsevich, just a quick question. Is there any Are the tests specific for a particular tract, or is there a significant overlap when you do one test for potential?
Yeah. I mean, good question. I mean, the answer is yes and yes. I mean, there are some tasks that, one can use, like take picture naming, for example. It's a gold standard task for a reason. And I think the reason is that, what does your brain have to do to name a picture? Obviously, you have to visually recognize the object, and then you have to access what's called your semantics. That's your fund of knowledge about that object. So if I see a picture of a horse, I start accessing, oh, it's a four-legged animal. It neighs, people ride on them, so I'm accessing all my semantics. Then you have to map that semantics onto what's called the lexical entry. That's the word that's associated with all that semantic knowledge. And you have to access phonological systems to put that word together. And then you have to be able to articulate that. So now you're engaging all those speech motor systems. So it's a nice, kind of global language test. But with that being said, there is some data out there that shows that you can miss certain types of language errors, or maybe it's not as sensitive for certain type of areas in the brain. So my approach typically is, I use picture naming when mapping most areas within the language system, but then I like to add maybe a second task when doing cortical stimulation to try to improve my sensitivity and detection. And I pick that task based on my understanding of the functional neuroanatomy and kind of, is there any data that supports that? So like JP was asking, maybe I would pick picture naming, but I might throw in some type of verbal fluency type task, or maybe I throw a non-word repetition if I'm, messing with ARCU or SLF3. That's my approach to doing this.
I think one we should also sort of realize that the anatomic location comes very handy also. So we kind of know the expected location of these tracks. So we try to put all the pieces together to identify the tracks. So we kind of know and in the normal parts of the brain, which are not distorted by tumor or mass effect, or not invaded by tumor, there is a fairly predictable location based on anatomy alone. So you can use that information also along with your sort of directional FA maps on 2D images. And then of course, then once you start identifying these areas of activation, you can actually use seed points, obviously, as Dave mentioned, that you can sort of confidently identify these areas of certain tasks more confidently than others, because then there will be more activation in certain tasks and less activation in the others, more specific activation in certain tasks, but there will be more than the activation of that center in any task, because the cognitive demands always are greater than what we expect, or it's far more complex than just that pure. So there is really no pure task, so to say.
Mm-hmm.
Thank you, Dr. Gupta. And Dr. Sepsis, I don't know if you want to comment on what you saw him when you saw before surgery.
Yeah, just go back one slide. I just want to make one last comment about that. I think one of the things that this picture just illustrates so well is that, when we go into surgery, right, we huddle, I'll be there with the neurosurgeon, and we come up with this kind of image in our head, even when we don't have these pretty pictures from Eric, right? So in our head, we understand what are the risks at each border of this three-dimensional surgery. I think that is huge for having a successful surgery. You have to think like this, and then there has to be communication between the surgeons and whoever's doing the mapping. So what we've done in some of these cases is, like Dr. Q will, break down the tumor into, let's say, quadrants, say, all right, I'm moving into quadrant 1 or quadrant 2. And I know what that means because we've talked about that. I know quadrant 1 might be the, anterior lateral border. So, taking some time, I think, before you enter the operating room and having this type of image in your head of the cortical and subcortical areas that may be very important is just, something that we should all be doing. You could go to the neuropsych. I don't know. What do I want to say about this? I mean, I think the guy, he did pretty well, as I recall. When we see people in the office, you do your little, you do your neurosurgical eval, it's, you don't find all the stuff that we would find using some sensitive neuropsych testing. So what we found in this particular case were just some very subtle weaknesses in kind of frontal lobe driven functions. It wasn't having any major functional impact on him, but they were noted, obviously, in this case, so that post-operatively, we can see if any of these things are any worse. And the data here might also inform what we do in the operating room. If somebody's got a subtle weakness in verbal fluency, what does that tell you? It may tell you that tumor has immediate proximity or some involvement, let's say, of the frontal slant tract. So we got to focus on that. So some of the weaknesses can guide what we might focus on intraoperatively.
Thank you, sir.
Yep.
So just a quick brief summary. In this particular case, we already knew the pathology, so there's no really differential, but we have a 35-year-old male with a history of seizures that has this lesion, hyperintense on T2 on the left frontal gyrus, posterior pars opercularis going all the way almost to precentral gyrus, some patchy enhancement. We already know it's a high-grade glioma, so we know that he's mostly intact with some minor language impairment. So the plan is to take him to the OR with an awake cranie so we can do actually intraop neuropsych monitoring and do as much as we can of a safe tumor resection. I don't know, JP, if you have any comments before the video.
Sorry, actually the comments that I have is just to resonate what in terms of the decision making and how to approach this, to resonate what Dr. Gupta and what Dr. Sapsevich just mentioned. In any surgery we do, as a surgeon and as a team, we got to think about the anatomy. And in this case, we got to think about the, let's call macroscopic anatomy and also the functional anatomy, and we got to put them together. So although we rely on the mapping for all the definition of the white matter, especially because it's just a sea of white that we see after we go beyond the cortex, we need to understand the normal anatomy. So they are to be placed together and not in isolation. And just like we shouldn't rely on navigation. We shouldn't always rely only on Dr. Sapsevich because you never know when he may get COVID or something like that and not going to be with us in the OR. So we should feel comfortable understanding the steps. And of course, we're blessed to have him and Dr. Gupta and the entire team here to work together. So once that's said, with the definitions of those areas, we were able to see that that's a very well-defined lesion. We feel confident that we can go and achieve a pretty successful external resection, help this patient to have a better overall survival and progress-free survival with the surgery. So let's go ahead and check the video.
Sir, so we skipped here the opening part as we already showed last week. You see here already an exposure. So just for some context and localization, here it will be posteriorly, anteriorly, this will be superiorly, and this will be inferiorly, and we'll proceed. So as you can see, Dr. Q and Dr. Almeida started doing mapping on the posterior section. We did place the circular grid, get 5 minutes of passive mapping just to have a baseline. And you see here that we started 1 milliamp, went all the way to 6, I believe. And we're now mapping a region that is non-infiltrated that we were suspecting based on fMRI that could have some eloquence. And you'll see that we did find a positive finding. So as we map, you will see now here, I think there's sound, but please let me know if there's sound.
And just to mention there.
Okay, now we got, did your tongue have trouble moving there? Correct. Okay.
Sorry,
perfect. Just to mention, no, perfect. Just to mention there, you saw that even without the mapping, even without we started mapping, we basically in that case used the mapping to confirm the location of what we expected to be a motor cortex related to the function of the face. So we know based on anatomy, and we confirm with mapping, which I believe for cortical mapping, it's the ideal expectation in surgery.
And I just wanted also to thank Dr. Sepsi for giving us these videos, which also always help the presentations. So as you can see here, I did skip some of the mapping, but as we discussed last week, in yellow, you do see that all of this area here were where we actually found, and one where we just showed the positive signal, but we did expect to find eloquence. And then with the aid of navigation and also anatomical landmarks, we didn't know that the tumor would be in black. So next, what you will see, I'm just gonna skip this, is that Dr. and Dr. Almeida proceeded to do mapping over the tumor just to confirm that we could actually do resection safely without risk of injury as much as we can predict. And then after we confirmed that there was no positive signal over the tumor, we moved the circular grid anteriorly, now more towards part triangularis and opercularis to do mapping. And you'll see that we will have another positive finding.
This is
So I don't know if it's that one is a bit more difficult to capture on video, but the patient did have significant hesitation when compared to his rate of how he was answering. I don't know, Dr. Sapsevitz, if you want to also comment on that.
No, I agree. I remember he's looking at a picture of a saw, and he had this delay in naming, and then I think we followed it up and were able to reproduce some naming issues at that site. I don't know if you're going to show videos on that or not.
I don't have it here.
Yeah.
I just had that one as a representative.
Okay. Yeah. So basically,
have,
when we find any type of finding like in that case, it might that's sort of in a gray area where I notice it and I'm like, all right, is it that he wasn't paying attention? What was going on? So we'll try to reproduce that with several other trials, and if we get any kind of consistency, then we start interpreting that as being potential functional. And in this case, we did get some naming errors in that area,
which is to be expected also based on the location. So what you see here now is that we now have a nice area defined between regions of eloquence where we actually can proceed with the resection. So you'll see that Dr. Q and Dr. De Almeida, now that they know where they can, the limits of how far they can go, they will proceed with a transsulcular approach for the resection of this tumor. Now the help of the bipolar, careful dissection, micro Caesars and micro dissection, always around the borders to try it as much as we can to avoid any injury to the patient while Dr. Sepsi is proceeding with neuromapping. And the important also considerations that the patient was also having some after discharges. He actually had one episode of a seizure, which was solved with cold saline irrigation. So very, very epileptogenic. And you see here also that we're proceeding with the dissection here, the more superficial part of the tumor. And as we proceed deeper, he started having more after discharges, and Dr. Q and Dr. Almeida also proceed with subcortical mapping, which I'll capture in a segment later. Here you see a nice plane being developed in the most posterior part. And actually there's an interesting finding here, which is that the patient started having a bit more dysarthria, which we expected to be not because we were actually resecting any important areas, but mostly because there was actually some traction. I don't know, Dr. Sepsevitz, you agree with that?
Yeah, no, that's absolutely right. I think once he started having some articulation problems, the surgeons were telling me that they were actually retracting. So they were pulling a little bit on that frontal area there. So that's why we thought that developed as a result of that.
Yeah, just to mention, like in terms of the technique, you saw that what we did, like just coagulate medial to the cortex that we consider to be kind of like safe cortex. So like, we consider this to be the cortex that we wanted to preserve. So we coagulated here, and then we went and found this area, which is the pia separating the two areas. So this gyrus that was the sick gyrus, and this gyrus that was the healthy gyrus. And then as you go with your suction or sonopathy, very, very low power, you find the layer of arachnoid between the two gyrus, and that's your landmark. And then you go from one side to the other side, as we did here. And where do you stop? You stop when you find the U fibers at the end of the gyrus, at the end of the cortex. And at that time is when the subcortical mapping becomes really your guidance, because then it's everything white. You're really going to have a hard time differentiating, and that's where we really rely on Dr. Sapsevich's support and everything.
And as we develop this nice pseudoplane, we proceed with the resection to remove this part of the tumor. And then you'll see here that we at the end with subcortical mapping, having more after discharges, the patient potentially having some initial deficits, there was a decision that was made to stop the surgery here with an almost cross-total resection. We do know there was potentially some tumor deeper, but the risks of resection would outweigh the benefits. So we proceed with the reconstruction. Dr. Gentoft, I don't know if you want to comment. I see Dr.
Hello.
Gentoft.
Can you hear me?
Yep.
Okay, sorry. I was having trouble with my connection. I had to go in on my phone. As you can see, this is a hypercellular lesion. It's made up of glial cells. There is atypia, and we do have mitotic activity. We do not have necrosis nor vascular proliferation. Therefore, this fits for a WHO grade 3 lesion morphologically. But as you know, we have to classify these from a molecular aspect as well. So if we go to the next slide. The tumor is positive for IDH1 and it is negative for ATRX. You can see some staining there, and that's an internal control. Those are normal glial cells and normal endothelial cells that are staining, but the tumor cells themselves are negative, indicating an ATRX mutation. This is consistent with an IDH mutant astrocytoma, still morphologically grade 3. However, we have to check the CDKN2A and B status of the tumor, which we did. And it turns out the outside institution did as well. We didn't have that information at the time, but received it later. And there was no homozygous deletion. Therefore, it is a astrocytoma IDH mutant WHO grade 3.
Thanks, sir. And here we have just the diagnosis, and the patient did very well after surgery. He was discharged home and had just some dysarthria in the immediate post-op and improved at follow-up. So the plan, which was discussed with neuro-onc and rad-onc with the patient, was to proceed, as data suggests, with temozolomide and radiation therapy, followed by adjuvant temozolomide, almost as much as it was GBM, just to protocol. And tissue was also sent for targeted seek in search for potential targets given the young age of the patient, which will potentially be helpful in the future. And here you see just some post-operative imaging, and on a T2 on the axial cut here on the left, you see almost a gross total resection, just some potential residual tumor in the innermost part, which was when we were finding highly eloquence and also after discharges. And here on the flare, you can see the same. And on the T1 post-contrast, importantly, you can see that the patchy enhancement was also removed. I don't know if anyone else has any other comments about this case. All right, thank you, everyone. I'll stop sharing. Andrea, whenever you're ready.
Yeah,
Thanks, Diogo. Very nice case. A really, really nice case. That will be also helpful for us to move along with the next case with Andrea as well. Thank you.
Thank you.